live feed, but let's see. I can see everything on your end. Yes. Yep, we're good.
Right. Well, there'll be no introductions because your hosts are your speakers. Tonight, we're going to be talking about glaucoma clinical case conversations. We're going to discuss some cases. We're going to discuss some imaging. We're going to discuss some perimetry. And hopefully, everybody will come away here with a few pearls. Now, these are the disclosures. My disclosure is I'm on the Speakers Bureau for Bausch and Lomb. All of my conflicts have been mitigated. Greg?
Yeah, there's the list there. I'll have to get you an updated list that's on there, but everything has been mitigated through COPE. And then Joe and I will be mentioning products, we'll be mentioning OCTs and visual fields tonight. We're not claiming any superiority over any instrument if we mention it. It's just we have to mention it. So no bias, no superiority, and everything's been mitigated.
So the audience understands we're going to be talking very conversationally. Hopefully, you're all going to be involved with the chat, which you can monitor that. Correct, Greg?
Yep.
Okay, and the polling questions. So Greg will have that. The first part of this, the majority of it, I put together some cases that I see in clinical practice. There's nothing going to be crazy here. It's stuff that you're going to see in a general ophthalmologic practice. Greg and I have other lectures on the really crazy cases, but these are good cases for discussion. And what I want to say is it will be relatively conversational and it will be unrehearsed. Greg maybe saw a couple of these cases many months ago. Some cases he hasn't seen. I know he got the handout, but I'm pretty sure he probably didn't study the handout. And, Greg, it kind of reminds me of something that happened in 1973 when Elton John and his band got together to write and record the double album "Goodbye Yellow Brick Road," and it's very well known. His band would say, he got all these lyrics from Bernie Taupin, and they said he never looked at it, he never studied it. When it came time to do a song, he'd sit down on the piano, pull some lyrics out, look at it, and boom, put it to music. So in much that same way, you're going to be doing the same thing, Greg. So are you ready to go there, Elton?
I'll give him a shot. So.
All right. Well, the first one is a 68-year-old male who comes in for a comprehensive eye exam in March. Thyroid dysfunction, he's on levothyroxine. He has a pituitary tumor removed many years ago, no recurrence. And I will preface it by saying that is not a red herring. That is not contributory to anything here. He is 20/20 each eye. There's no relative afferent pupillary defect. Gonioscopically, he is pigmented trabecular meshwork, both eyes, 360, moderate pigment, and moderate cupping, 55 and 50 cup, no focal rim defects. But you can see, and I have to apologize for the, really kind of poorness of the photograph. We've all got our technicians, and I've got my lead technician is a wonderful assistant, but photography is not her gift. But you can see that there is a pretty significant flame-shaped hemorrhage in that glaucoma-prone zone, inferior temporal. Pressure is 11 each eye, and central corneal thickness is right there at the edge at 499, 500. Greg, any comments on the well, I'm sorry, it's a poor disc photo, but any comments about that hemorrhage? I mean, that part's pretty obvious.
Yeah, I mean, like you said, Joe, it's in the glaucoma prone zone. Not all disc hemorrhages are glaucoma. I mean, it is suspicious looking at that. It's right up against the neuroretinal rim. Remember, some disc hemorrhages can be from PVDs that are out there. So this person's right in that age of a PVD. I'm going to make a couple comments on your history here. The pituitary tumor, I know you said there's no red herring, but I want to remind everyone that, remember, a pituitary tumor on a visual field creates a bitemporal, but on a, OCT, it can create a binasal in the macula. So maybe if there wasn't a visual field defect, we might see some nasal issues there. And then pressures are low, but I want to comment on that cornea thickness. We don't want to adjust up or down, but they are thin. But the patient doesn't have ocular hypertension, so we really can't really apply any study to this, right? So the ocular hypertensive treatment study, basically, I just saw Dick Bennett recently out at the academy, and I was saying, hey, remember, you're not the only optometrist that was in there, because I was doing my residency at that time. This patient could not be enrolled, so I would just say that they're just a poor LASIK candidate. But I mean, if you want to throw maybe some risk in there, but we don't really have a study to support it because this patient does not have ocular hypertension.
And one thing I want to point out with is gonioscopy and central corneal thickness weren't really part of a primary examination here. It was that disc hemorrhage that twigged all the rest of the testing, because the pressure was not substantial, and the optic nerve appearance, aside from the hemorrhage, was not substantial in either eye, either eye. So that would not have triggered anything. It really is the presence of that hemorrhage. Now, had the person come in 6 weeks earlier or 6 weeks later, we may not even be discussing this. All right, Greg. So here is our entering OCT, and I'm going to ask that you go through that, and keep in mind, or the audience should keep in mind, that the area of concern was that left eye, inferior temporal, where the hemorrhage was.
Well, I mean, it's cool to see that you in your Venice office that you have an OptiView instrument here. Not that it's superior, but that's what I've been using for years and teaching off of. So what I would like to do is, I want to look at in the middle of the OCT here. I want to look at the optic nerve. We can see that on the right optic nerve. I want to look at the images, the B scan images. You want to point those out, Joe, in the center there.
Mhm.
The top one has a little PVD there, so that's kind of neat. It's attached right there. That could release at some point, and then we're going to get a few microns worth of, you can see even it's kind of hyperfluorescent there. It's going to release and maybe give us some few microns of thinning, and we might go, ooh, that's a change. You can see that the macula, there is no traction on the you can see the PVD there. These are clear. They're well centered. So at least we're getting the optic nerve. We're getting the macula. Then you jump down to this other optic nerve, and I guess a comment that I would be is look how deep the one cup is, and compare it to the other uh, cup. One's deep, one's shallow. And then you look at the macula, and you can see that there's the PVD has released. So what I always like to point out when I do OCT talks is that, the vitreous is alive. I've seen, the vitreous pulling on the macula. I've seen pulling on the rim like it's up there. Then it releases, and you get a few microns, and then people are going, "Oh my goodness, this is a progression." So I like those. Again, they're good scans. Now let's jump over to the numbers. I like to start with the ganglion cell complex. I'm looking for symmetry here. And that when I was working with OptiView, I had them put these numbers in. Not that I couldn't subtract them, but I just wanted a quick and dirty. So if you look at the ganglion cell, the right eye, the average is 100, and then 94, and then superior is 99 and 101. So it's a 6 micron difference, a 2 micron difference, and a 13 micron difference. So that 13 is concerning. I scratch my head in the ganglion cell when that starts getting around 9, 10. So that 13, and in that inferior region, that's kind of where that disc hemorrhage is. Now, the focal loss volume, you don't really have to worry about the percentages. It's kind of a really strange algorithm. I just look to see if it's green, that's a focal loss volume. The general health is good. So that little inferior area is, if you want to say, is a little concerned, but it's still nice and thick. The ganglion cell numbers, I always say, should be between 85 and 100. And then symmetry is important. So you can see the right eye is 100, 99, and 100, and then 94, 100, and 87. Jumping up to the retinal nerve fiber layer, those look really good. 102, 104, 100. Again, symmetry is the key, and that's why that column is in there. And looks like it's 1, -3, and 5. And then the disc numbers, the analysis, I don't really use that too much, other than I like to see if they're kind of macro discs or micro discs. And that's off the disk area, and you can see 1.5, 1.6. The other stuff that's all in there to help make the calculations. But I looking for glaucoma, I use the nerve fiber layer and GCC. Jumping down to the T-SNP, you can see that they're really pretty much on top of each other, kind of mirroring. And then Joe, jumping over now to the left side, to that left eye, we have, if we look at the rim, then of this optic nerve, I guess go to the right eye, the rim, I can see 140, 78, 62, 148. And that 140 and 148, that's your glaucoma prone zone. I'm going to go now compare this to the left eye, 140 and 144, and then 125 right where that hemorrhage is. And comparing to 148. So, I mean, it could be a little thin in that area, but again, it doesn't have to be glaucoma. In this case, glaucoma is our number one cause, but I see a little thinning down in there. Nothing that's super concerning. So,
And what about these little deviation map here?
yeah, I mean, in the deviation map, I mean, in a sense, it's kind of like a topography area, and you can see just outside of the fovea. Remember, the fovea doesn't have any ganglion cell layer or ganglion cell complex, which is, I believe, the inner, the nerve fiber or the ganglion cell and the inner nuclear layer, and then the internal limiting membrane. And that could be, the optic nerve in that nerve fiber layer area. That could be some thinning from that disc hemorrhage.
Okay, I don't think there's anything I would add to that. So let's look at the visual field now.
Yeah. Let's see. Right eye. Okay. Left eye. All right. So I see how you have them here. So let's go. The left eye was the concern. Let's look at the right eye first, since it's on the
Left side.
on the left side here. Let's see. What did you do? Did a 24-2. Phobia's off. All the parameters look good. False positives, false negatives. It is a +5. So we gotta be careful with rim defects on that there was a +5 used on this. But jumping and looking at all the parameters, going to look at the deviation, looks clean, pattern looks clean, the visual field index is 100. The mean deviation is actually plus, it's a little bit above for a 68-year-old. Pattern standard deviation, remind everyone, tells us how localized a defect is. There's no defect on this visual field. Jumping over, it was an inferior, so we think of a superior defect. That potentially could be happening. Again, fovea is off. It's a 4-minute visual field, a +5 being done. Everything looks pretty reliable. Jumping down, the visual field index is 99. It's a plus again, 1.05. I don't see a defect here, even though that pattern deviation there is, could be related, superior there. But if you look at the total deviation, it's clean. The false positives in this patient being a little bit more reliable is pushing that down. And that one defect is coming from, if you want to point out, Joe, that 28 up there. There's that one spot of 28 in the raw data right there. And that's, so it's 28, which is probably normal. But then because look at these 35s and 34s, and this person's a plus and they're 68 years old, the visual field gets pushed down. So that 28 probably got pushed to a 26 or a 27. Well, you can see it right there. It got pushed down 5. If you go down to the pattern deviation, right where that 28 is, Joe, um, you see where it says -5 and circle it right there. So if you look in the same spot in the total, it's -2, but it pushed it down 3 more to a 5, and that's why it's flagging it. Because this visual field is a little bit, if you want to say trigger happy, it's above, so it adjusted the whole thing down, and that's why that defects show up. That's why typically it raises the visual field. So going from total to pattern, we usually see them improve. But in this case, what happened is the total is good and it made it show up more because this is a plus on the mean deviation, a few false positives. So both visual fields have been pushed down.
Yeah, it's worth noting that typically the pattern deviation will be better than the total deviation. And when it's worse, as we see here, though it's very mild, it's either an unreliable field, which is not the case here, or it's a little bit of noise in the system as you just described. Anything
Well,
else here,
the
Greg?
patient 68 years old is,
Hmm.
they could be more sensitive than maybe the average, and it's just pushing it down. But again,
Yeah,
they're not anywhere close to going blind. So
and I think that what I like about this, or what I give credence to, is false positive is similar, very low, and the mean deviation is really pretty similar. Both are positive. So that kind of tells me that this may actually be the patient's physiology. All right. So that brings me to polling question number 1. What do we do here? Do we treat the patient with meds? Do we treat the patient with an SLT? Are we going to observe the patient or do something else? And put that in the chat. I'm going to have you monitor all of that for me, Greg, because I can't see it when I'm in full screen.
okay, the question is open for the polling question. So what would you do? Treat with meds, treat with an SLT, observe, do something else. If you're going to do something else, put it into the chat box. I'll monitor that.
They're rolling in.
Yeah, they're rolling in.
Good.
Just trying to get those numbers up. Remember, everyone, this is synchronous. This all gets tied into credits. So please answer the polling questions. It's the second button down. And display is the trend is set, Joe. We have 6 treating with meds or 13%. We got 1 referring for an SLT. We got 81% that are observing. And we got something else going into the chat box. So let me see if there's anything in here. Let's see. Um, observe closely. Imaging. Someone wants to have an image done. Maybe a CT scan from the above chat. What would treatment objective be? IOP 8 question mark. Systemic workup. Rule out ischemic causes. Okay. So there's some thoughts for you there, Joe. And we'll go back to
All
the
right.
polling question.
All right. Very good.
And
Very good.
yeah, everything's pretty much the same.
All right. So we'll move on.
Yeah.
All right. Well, my approach was, let's observe. I don't think there's anything that is suspicious or overly suspicious or concerning in the OCT or visual field. And if the disc hemorrhage was not there, we never would have gone down this diagnostic pathway. So I bring the patient back when I'm observing closely. My definition of closely in this situation is every 6 months. Comes back about 6 months later. He's asymptomatic. His vision is unchanged. His pressure is 13 in each eye, and there are no changes in the optic nerve. And here is his visual field. So you want to take a look at this one, Greg, and give us your thoughts here.
Yeah, again, let's look at the right eye. I won't go as in detail. This one's a lot shorter, right? 2 minutes. Looks like you did a CETA faster. Fovea's off. Now we have a 450 in there. Patient 69 years old. So the glaucoma hemifield test on the right eye has given us an abnormal high sensitivity. Again, that's because they're plus 175 on a 69-year-old. Pattern standard deviation is telling us that it's kind of diffusely scattered. That's a low number. Higher the number, more localized. But looking at the total deviation, that's clean. And if you look at that pattern deviation on the right eye, where you have that less than 0.5%, that number is 30, and it's dropping it to 6 points there, and that's why it's flagging it. So that's why it's normal to me. That's normal. He just got an abnormal sensitivity. So right eye looks pretty clean to me. Jumping over to the left eye, the one that had the hemorrhage in it, everything looks good. With your testing, there's a +5 over here. Total deviation's clean. We got one spot right below the horizontal there. That number in the raw data is 31, and that's a -1 on kind of the normal, comparing it to a normal 69. But since they are a plus 1.58, what it's doing is pushing this whole visual field down. It pushed it down to 4, and now it's flagging it as whatever that one is, less than 2%, being normal. And but within normal limits, 100%. To me, these visual fields are pretty clean. Why no blind spot in the left eye? Joe, why no blind spot? I would just say that it was plotted, and yeah.
Well, a couple of things to add into this. If you notice the false positive, we have abnormally high sensitivity. The false positive is at 0%, actually is in 0%, both of them. Now, we agreed previously that the patient was in the green with a positive number. Now, it has gone up a bit. Now, I think the consideration is previously it was a CETA standard, now it's a CETA faster, and I think that those deviations could reflect the different thresholding algorithm used. But if you notice, at 1.58, it is not flagged. At 1.75, it is flagged. I don't think that this is an unreliable field. I actually believe that this is representing a person who is above the norm. All right, so really nothing's happening there, and here is
So
our
the only other
repeat.
comment that
Yeah,
I'll make
yeah.
is, we're getting the question, why no blind spot? It was probably plotted, and then when the patient took it, it's just not really, showing up as a blind spot. But Joe has to me, what I would go is more reliable is the gaze monitor at the bottom, just for, I guess, for the slide purpose. It's just not showing down there.
Hmm.
Uh, but the gate. Oh, why no blind spot is? Do they turn it off for CETA faster? These are CETA fasters. There's one there, but they're not one over there. I was forgot what they turned off the false negatives. But we do the gaze monitor is what I would go by instead of blind spots. Because here's why. I've watched my technician. She's amazing. She puts the patient in there. She plots the blind spot. They got the eye all patched up, and she goes, "Okay, we're gonna get started." And the patient goes, "What'd you say, honey?" And we just undid the blind spot that was all plotted out. So they pulled their head out. They said, "What'd you say?" They put their head back in, and now, unless they replot it. So I'm good.
All right, here's the OCT repeated after 6 months.
Yeah, I mean, I
Any
always like looking at the B scans. I mean, when I do interpretation, you can still see that if you want to call it that vitreotraction to around the optic nerve head is still there. The PVD over the macula in the right eye is still there. You got a little bit of traction down there in that nerve. Now this one's got more of a cup, so that's, the first one didn't have a cup. Now this one's got more of a cup. And now we jump down to the macula. It's no traction on it. That's a full PVD release. So, okay, we're pretty confident that, we're looking at neuroretinal rim, neurofiber layer in a sense, and the ganglion cell. Jumping down to the ganglion cell averages, again, between 85 5 and 100. If you just look at the right eye, 100, 99, 101, 94, 102, and 87. That's 6, that minus 3, and there's that 14. Maybe there's a 1 difference there. It's not enough for me to call progression. Focal loss volume, it's saying it's healthy. Globally, it's healthy. And going up to the retinal nerve fiber layer, again, symmetry 103, 102, 104. And we got 98, 97, and 89. There's that 15 difference. So those two 14s and 15s are enough asymmetry that we have to, as Joe's doing here, follow this person. But nothing really shaking. Okay, right eye, the ganglion cell complex map looks good. The neuroretinal, the nerve fiber layer around the rim, it's all flagged as green. The glaucoma prozone, it's 135, 152. That might be that little traction on there because I think it was a little bit thinner before. That could be the difference between that being pulled up a little bit, being 150. They're usually not that high. They're down around that 135 range. So that traction up there in that on that nerve, if we could go in and look to see where it is. It is hyperfluorescing up there. If you want to point that out, Joe, in that B scan way up there in that vertical cut in that B scan, go right there. Yeah, see that right there? It's hyperfluorescing.
Mhm.
So, I think that might be where that 152 is coming from. And now you got the 15 micron difference. So you got 146 and then you got 128 down here. You still have that little defect carrying through in the macula. I might take a look at the scans and go through the cube just to see what it is, but again, I don't see anything progressing and things look pretty good.
All right. So continue monitoring on a 6-month basis. He comes in asymptomatic, vision unchanged. Pressure is 11 and 12, but now he's got a new disc hemorrhage, recurrent, in the exact same place. So now he's had hemorrhage number 2 in the same place. Any thoughts or comments on that, Greg? So now we're rounding at least our second disc hemorrhage.
Yeah. I mean, there's the body's talking to him, right? Where were we? What lecture did we recently hear? I thought it was a great way. It was Rich Madonna, right? A glaucoma eye is usually plugged into a sick body from 100 years ago. Whoever said that. So, is it glaucoma, primary open angle? Okay, maybe normal tension, but to me, whoever said maybe systemic workup a little bit earlier, there's might be something. The body's speaking to us, but it's not in a high pressure glaucomatous. So it's more probably systemic going on here.
All right. So here's our visual field that goes along with it.
Yeah, right eye looks pretty good. Again, plus 450 is all good. Fovea off. Few false positives. Total deviation's good. Pattern deviation, like one little spot in there flagging at less than 5%. Within normal limits, 100%. Again, plus for 69 years old. And then jumping over to the left eye, again, that same +5, it's a CETA faster, it's a 2-minute visual field, and total deviation looks good. And the pattern looks, it's a plus. So there's little areas where that less than 5% get flagged a little bit higher, and a couple other pop up for the fact that it's being pushed down, but now your visual field's at minus 0.1 decibels.
Yeah, so both have gone down, probably more the left eye than the right. And I think we can also attribute this sometimes to just test-to-test fluctuation. Your thoughts on that, Greg?
Yeah, I agree. I mean, nothing's crashing and burning. Is this a year
All right.
later now?
Probably about. All right, now, polling question number 2. Now the person has had at least his second disc hemorrhage. Pressure's 11 and 12. Previously it was 13 and 13. And then before that, I think it was 10 and 11. So polling question 2, do we treat with meds? Do we treat with SLT? Do we observe, or do you want to do something else?
Polling questions open. People are responding to it. Nothing else is in the. Oh, here we go. We got more stuff popping into the. We got a part. We got request for an MRI, and
I
then
guess
what? Okay.
the question is that I would pose is, why does somebody want an MRI? The features of non-glaucomatous neuropathy tend to be disc pallor. In fact, there's a very good study done out of Bascom Palmer joint effort between the neuro-ophthalmology department and the glaucoma department, trying to differentiate normal tension glaucoma from patients who actually had compressive lesions. One thing they found out was a disc hemorrhage was 100% specific for glaucoma. Not one tumor patient developed a disc hemorrhage.
So with MRI being kind of maybe ruled out based on that, how about we're getting systemic workup?
Well, he does have a primary care physician. He has this thyroid. He's using levothyroxine. Beyond that, his medical history is okay.
And then there was a kind of a billing question that rolled in. So what do you bill OCT and visual fields as glaucoma suspect? Yep, that's what it's listed in the chart. So glaucoma suspect is totally fine. That's what you're following them for. You're having the discussion. So visual field can be billed as glaucoma suspect and along with the OCT. We're getting a report. We're getting a comment on sleep apnea question mark. And we're getting people saying blood testing, agree with systemic workup.
All right. Well, so ultimately out of the chat, what's the polling saying?
Polling says, and I'll display that. We've got treat with meds, 17%, SLT, 15%, and we have 50% observe. And then the something else is, well, that's what they're putting into the chat. I already read those.
All right. Well, my approach was continue to observe. There's no threat here at this point. If we were looking at different time periods, we'd be missing these disc hemorrhages. Well, comes in 6 months later, he is asymptomatic. His vision's unchanged. His pressure is 10 and 12, and this is what we see. Any thoughts here, Greg?
I'm just checking the chat real quick and I'll get to you. We're getting a bunch of sleep apnea, systemic workups, and sleep study for sleep apnea. Okay. Let me just look real quick and see if there's anything comments. You still got in your neuroretinal rim up there in the right eye, 143, 149. The ganglion cell looks good. Jumping down here to the left eye, looking at glaucoma prozone 138. A little bit thinner down, a little bit at 118. I think it was like 125 at one point. Looking at the B scans, still got that PVD up there, that traction, PVD in the macula. Still got a little bit of traction like before. That cup is a little bit, it's deep like before. Um, let's look at the nerve fiber layer 103, 104, 102. That looks good. 98, 106, 91. Now we're down to 11 difference. Going down here, starting to see some yellows. So let's see what it's flagging up here. 98, 97, 100, and then 91, 99, 84. That 84 is now being flagged. We got the 16 difference. And that focal loss volume there, it's being flagged as, hey, this is pretty powerful. This is very strong in specificity and sensitivity. So there's a little bit of weight when I start seeing that change. Jumping down to your T-snit, Joe, you can see that kind of on that one eye there, and that inferior starting to flatten out. And you're starting to see the difference there. So, they're getting changes down here in this inferior area. Maybe, somewhat changes, but nothing it's
That's
crashing and
interesting.
burning.
There's actually an increase up here while there is a decrease down here. And what we're trying to get everybody to understand is there is noise in the system. There is test to test variation. And when we read the studies, remember these are trained observers, very rigid conditions. Now we're talking these. This is what happens in real clinical practice. All right, so let's look at a change analysis. Greg, why don't you touch on this then?
We got a right eye here. You can see we've got 3 scans from the 20. Let's see, we got April 22nd jumping to, so we got about a year and a half here, which is, a nice progression. I usually start with the GCC. I usually, looking down here at the bottom right-hand corner, um, the confidence interval in that's a little bit wider than I would expect for a macula scan. Let me just kind of point out that when you're doing an OCT, you're looking, when the technician is doing it, whatever color the light is, red, green, look at the green light while they're using their macula. And when you do nerve fiber there, they got to look nasal, and the light's over there to try to line up the nerve. So if there's going to be more in the confidence interval, which is that gray zone, it's usually a little bit tighter on the ganglion cell. A little bit, I'll give a little bit of fluctuation on the nerve fiber layer. So there's a little bit of noise, as Joe said here, because of that confidence interval. And it's saying that the rate of progression is 1.06 microns per year. It really hasn't flagged it statistically, but you can see it started off at about 100, and we've drifted down just below the 100 mark on the ganglion cell. And then the nerve fiber layer, it's kind of got a little uphill trend. We got one that's an uphill trend, one that's a downhill trend, and that's the right eye. So to me, there's nothing going on in the right eye.
And left eye?
Um, let's see here. So again, let's see. I always just like to make sure that we've got the right scan, so we're good. Um, so let's start with the ganglion cell. Again, we started off about 95. We drifted down to about 90. It's not even flagging. I'm kind of surprised at 2.2 because it will highlight it on the instrument like, hey, doc, take a look at it. So that box sometimes becomes highlighted where that 2.2 microns per year is, with the confidence interval. So we started at 95. We're drifting down. You can see here now that the confidence interval is a little bit tighter in that grayscale, as opposed to now the nerve fiber layer. It's typically what you see, because again, it's hard to get that nasal fixation when they're cranking their eye over. But we started with 100 and drifting down, and we're getting about 1.8 microns per year, not being flagged. I forget, normal is, a quarter per year over the time. But again, the vitreous is alive. There's PVDs on this nerve. So, you just kind of have to take that all into account. So, um, looks potentially, if you look at the nerve fiber layer analysis, looking at the rim over here, 125 inferior where that hemorrhage is, 120, 118. We've got a 7 micron difference, still in the green and kind of matching up there in that little islands of red. I think those hemorrhages are causing damage. Okay. I don't think there's any doubt that these hemorrhages, this nerve structure, is it glaucoma? I'm not convinced, but I think that there's something causing, structural change here.
So polling question number 3, is he progressing? Yes, no, or I'm not sure.
Okay, polling question is open. Answers are rolling in. Nothing else other than Systemics and the old ones, questions that are still in there are sleep studies and systemics. So back to the polling question. Is he progressing? Yes, no, I'm not sure. And we've got a pretty good amount of responses already. I'll show the trend. We have 40% yes, 17% no, and we have 43% not sure.
I think probably the patient is showing some structural change. So that gives me the polling question number 4. I'm going to give you a summary. He's now 70 years old. Pressure ranges 11 to 13 right eye and left eye. Central coral thickness is right at that 500 mark. He's had 2 disc hemorrhages, left eye, inferior temporal, and we've looked at the OCT and fields. So now the question is, do we treat with meds? Do we treat with SLT? Do we observe the patient, or do you want to do something else?
Okay. Polling question's been open. The answers are rolling in. Okay, let me get some display this here. We've got 20% going with treat with meds, 16 going SLT. We got majority with 56% going with observe. And we got
Excellent.
something else going in, and they'll put it in the chat. And I don't see anything different in the chat.
All right. So my
Oh,
approach was because
it went
we,
tough. It's a hold on, tough to treat with IOP solo. That was the
I was
comments.
going to say exactly the same thing. You do 2 meds and maybe an SLT, and you get the patient down by 2 or 3 millimeters. Question is that helping the patient? Well, let's take a look at his most recent. Anything concerning here, Greg? I mean, we're never really concerned about
No,
with the right eye.
no. The right eye, actually, the nerve fiber layer is going up. That's probably in that nerve fiber layer. It's probably that traction that I keep pointing out
Hmm.
in there, and that's probably what's drifting it up. Let's see if we can pick up what number might be doing it. Yeah, start off 115, 126. I'm sorry, I'm looking at the wrong numbers. 149, 152, 149, 156. Yeah, started off at 149 in that inferior, we're up to 156. Started off at 140, and now we're up to 150. So there's probably the vitreous. If you want to point out those glaucoma prone zones, Joe, superior temporal, inferior temporal on that very first scan in April, and that's 148, 146. Now we're 150 and 156. It's probably that traction. You can kind of see it over there in the T-stip naps. They're starting to go up and out into the white zone.
Hmm.
You're probably PVD is forming in this eye, is what I would call. And then that's going to release. And then we're going to
Hmm.
go, oh my gosh, look how much that nerve fiber layer changed. And then we're going to say we need to treat that. So.
And now here's our concerning eye, the left eye. What are your thoughts here?
Well, let's just look at the glaucoma prone zone on the nerve fiber layer. Well, I'll just go superior temporal, 144, 146, 138, back to 144. That's the superior temporal I just read across. Now I'm going to go inferior temporal, 125, 120, 118, 113. So you could see that in that inferior range, but it's still green. It's because we got a lot of play in there. But when you look at the average nerve fiber layer and the scale down there, it's just a slight drift down. And then, the macula is, in a sense, pretty steady. So now we've gone to microns per year, you know, 0.81 in the nerve fiber layer and zero point 0.7 in the nerve fiber layer. So whatever it was is slowing down, probably because he didn't have another disc hemorrhage. Go back, Joe, real quick. I want to see what the progression is on the. There you go. Look at that change. Um, Oh, go back. I'm sorry. There you go. Going up 2.83, and that's the traction. The rate of progression. Go back one more. Go back. Sorry. It was 2.83, and I didn't get to see it on the there you go. And up 0.19. Okay.
And here are his visual fields.
Yeah, I mean
So
it's not the full one on the 24th, but you can see that they're both going straight across in the glaucoma progression analysis. So you
mhm.
can look at the mean deviation in the left eye. It's or the visual field index is 99. The mean deviation is 1.02. The pattern standard deviation tells you that it's diffuse. Jump over to the right eye. We got 100% on the visual field index. We've got mean deviation plus 1.3. So, maybe we have a pre-parametric defect going on. So the visual field's totally normal. While we might have we do have changes now, just where are the changes coming from?
So there are changes. I think the important thing to understand is glaucoma is a progressive disease, but the mere act of progressing is not necessarily deleterious to the patient. It is what is the rate of progression. And right now we need one more visual field, which is coming soon, to see what the true rate of progression is. But in the left eye, it is holding very steadily. And I think if we had started and lost our nervous system the first time we saw a disc hemorrhage and started treating, we'd probably be in exactly the same spot. Do you agree, Greg?
Oh yeah, I agree. Yeah. Yeah, the other comment is if I was going to treat this patient, it probably wouldn't be an SLT. I don't think it would lower much. If someone said, "Hey," or the patient said, "Hey, I want this treated," I'd probably go Notarsadil. Really, just treat this patient. Notarsadil will lower a low IOP. It also works on the episcleral side. I mean, if I was going to take a crack at something, that would probably be the medicine that I would use. I'm not sure if I'd use a prostaglandin. I don't know if I'd use Cosopt or Combigan. I'd probably go with something that lowers a low IOP, and that's where the Tarsadil shines. But I wouldn't be treating this patient yet. So
Well, I mean, we are treating the patient, but we're treating with observation.
observation. Yeah.
We're not intervening medically or surgically. So we had discussion risk benefit and alternatives, and he's very happy to do this, and his life is not impeded at all. So just going to continue to follow him. All right, Greg. Case number two, 71-year-old male comes in for a routine comprehensive exam. He's a myopic astigmat, 20/20 correctable each eye. There's no afferent defect. Biomicroscopy is normal. He's got some mild nuclear sclerotic cataracts. His pressure is 20 and 22 with 575 and 580 central corneal thickness. His disc appearance is a 65 in the right eye, 60 in the left, with some inferior rim thinning. I don't have any good photographs of this one. Gonioscopically, he's open to ciliary body superiorly and pigmented trabecular meshwork everywhere else in each eye with no abnormalities. So pertinent 71, pressures 20, inferior thinning. Here is the visual field.
So before you move on, Joe, go back. I want to look at the history a little bit. Some comments are rolling in from the previous case. Consider an ERG, Sandra. That's to me a great idea. I have zero experience with it, so I'm not sure if you want to put any comments in the chat box. I think an ERG would probably show, probably a defect over there. Still, what would we do with it? Would you treat it, not treat it? Would it help us determine the underlying cause of it? But I think it would probably show that there was, one eye working quicker than the other or better than the other. And then Joe, we have, question what's the cause of the retinal hemorrhage? Um, I mean, I'll answer it as, disc hemorrhages, what we do know is that, there is structural changes happening to that optic nerve. The lamina curvosa is shifting, the capillaries, there's this, there's a shearing, and, you're choking off a hemorrhage and you're getting a disc hemorrhage. Now, is it low cerebral spinal fluid? Is the blood pressure dropping? Is this patient, those are the kind of things that we, could be talking about. Is he taking blood pressure meds at bedtime, and he's bottoming him out his blood pressure, and different things like that is kind of where I'd go down with this case. But the retinal hemorrhage is coming. I don't really see a PVD there because they're shifting and shearing around that optic nerve. We do know that. That was some pretty cool stuff that they talked about at the Optometric Glaucoma Society meeting this year. But is it from glaucoma? Is it from blood pressure? Is it from, a drop in the cerebral spinal fluid pressure? But Joe, I'll
Yeah,
let you take a crack.
I think that it has been shown pretty reasonably well through enhanced depth imaging OCT that there's a shifting of the laminar tissue, causing, just as you said, Greg, a shearing of the blood vessels. Not really a ischemia, but is actually a mechanical phenomenon. It just really hasn't manifested in the previous patient as a functional defect. But let's
So
look at this one.
came in, is the patient still a glaucoma suspect, and based on what? Well, if you want to crack at it, and then I'll take a crack at it.
I call the patient mild stage glaucoma in the left eye.
Yeah.
There
So I mean,
has been some changes.
yeah.
Mhm.
Go ahead.
Yeah, I consider it mild stage glaucoma left eye, glaucoma suspect right eye. And only suspect right eye because it's attached to the left eye.
Right. Glaucoma is usually a bilateral disease. So yeah, I think it's still called a glaucoma suspect. I think, or more mild glaucoma and a glaucoma suspect in the right eye, just as Joe said. And monitor this patient. Maybe something will manifest, over time. I think he got an optic neuropathy going on here. And I think there's all kinds of optic neuropathy. That's Joe's wheelhouse, but you got infectious and ischemic and all the different optic neuropathies, but the number one is glaucoma. We have progression here, maybe related to something else systemically, but I think for your answer, you can call it glaucoma suspect or even glaucoma.
Yeah, I would call I have listed the patient early stage glaucoma left eye,
Since you're
glaucoma
doing
suspect
that, the
right eye.
question came in, do you have to treat?
Do you have to treat? We are treating, we're treating with observation.
And the
We're
patient
just not doing
elected not to have treatment, right?
correct. We had risk benefit and alternative discussion, and he was perfectly fine to be monitored. And he is a very good patient, as you see. He comes in as scheduled every 6 months.
Progression because of optic nerve cupping appearance. Um, Joe, you looked at the optic nerves. I did not. I'm just going off of
Mhm.
OCT testing.
And that's mostly what I'm going off of as well. There has been some changes in the ganglion cell complex. There is some noise in the system, but it is not parametric at this point.
And what's the etiology of the nerve damage?
Glaucoma.
Okay. And okay, the OCT, got it. All right, perfect. Are we assuming his IOP is higher in the middle of the night when he is asleep?
I don't know that we can assume that. Studies have shown that on average, that is what the trend is, but also there are patients who do not follow that trend. And I don't think it is substantially higher in the left eye than the right eye.
Good.
Anything else?
I think, how carefully do you try to assess the patient's life expectancy?
Uh, it is consideration. It is a consideration in one of our cases, though I don't know we'll get that far this evening. It is The previous patient was hitting 70. I don't know in a person who is otherwise healthy how long they're going to live. We only know actuary tables and what the averages are. People age at different rates, and I tell that to patients all the time. And I remark that Joe Biden and Mick Jagger are the same age, but they have aged differently. And I also like to say that the only people who have the luxury of knowing exactly how much time they have left are people who are on death row. So we have to
Yeah,
consider it. I don't consider 70 to be very old, though.
I'm the same way with the 70 being not that old. My rule of thumb is I tell all my patients, I'm going to treat you as I'm going to treat you and follow you as if you're going to live to be 105 to 110 years old. So to me, this person, if they were 70, Joe, would have another 30 some years. So I think, observation closely is a great treatment. Um, and maybe as time goes by, something will manifest. Listening to this case here tonight, maybe it is, a talk to the primary care doc, but that's kind of I wouldn't send a letter. That's going to be a phone call talk, be like, hey, listen, this is what's going on. We're kind of looking for a needle in the haystack. It's not blood pressure, diabetes, the metabolic conditions, because that's what if he's seeing a PCP about, we're going for the sleep apneas and the low and you know taking blood pressure at night and bottoming out type of things is what we're looking for. So
Yeah, he's out on blood pressure medicines, and in the conversation when they ask, well, how bad is his vision, and I say, oh, it's perfect, and they're going to say, well, what's the problem?
yeah, Scott, the treatment that Joe's trying to point out here is the diagnosis of glaucoma. Is it required? I don't think it's required. Joe had the discussion of risk versus benefits, and his treatment is observation. He and the patient. I have patients, for religious reasons, do not want treated. They don't want drops. They don't want SLT. For whatever reasons, maybe whatever it might not be religious, but they don't want treatment. I have it documented in the chart: risk benefits, risk of blindness, blah blah blah. Patient decline treatment. We'll continue to observe. I've had probably about 4 of those in my lifetime, and then when the one eye got to where they could barely see, then they decided to treat the other eye. So does it is so Joe is treating it, and the patient is treating it, and they're treating it through observation. So if you're looking at, does it need to have an SLT or some type of drop or surgical consult and MIGS procedure? I don't think we need to do that as long as risk benefits questions have been discussed and the patient elects to monitor and observation. Remember, I type it in the chart all the time. Treatment is observation. I type that every single
Mhm.
day. Probably I'm in there. Treatment, observation. When I go and interpret my OCT with my electronic health record, tell me, what did you do? What did you find? Is it progressing? What's the treatment? Observation is treatment. Observation is treatment. I type it all the time. My visual fields, I type it in my OCTs, I type it as the plan. So treatment, we got to wrap our minds um, that observation is treatment. Cataract, cataract is there. It's a disease. Are we treating every single one? No, we're observing it for further density and visual acuity loss.
And also remember, we're starting with an average pressure of 11 in each eye. The question is, are we sufficiently intervening and treating a patient, or are we treating our own conscience, and we feel better, and if nothing changes, we feel we did a good job by subjecting the person to lasers, medicines, or surgery when they may not be getting worse at all.
And I think we're good.
All right, well, Greg, case different patient, 72-year-old male, very similar. 2020, pressure 20 and 22 at initial visit, 65 cupping, 60 cupping, inferior rim thinning, gonioscopically open. Now bring the patient back for a visual field. And when the patient comes back for a visual field, pressure is now 18 and 20, so that's a second pressure. What are your thoughts here?
Just let me see what you did on this patient. Now I got the fovea on. I like that. 36 decibels. I like that when it does it because it warms the patient up. I also like to see if they're kind of getting the test. This patient should be 20/20. I think that's what you said on the
Yes.
on the acuity,
Mhm.
just based on that decibel, they're 20/20. Looking at your RX that's in there, they have some cylinder corrected. That's good. 68 years old. And jumping down to looking at it, within normal limits, 99, just a smidge below zero at negative 0.2, very diffusely scattered. You got one of the dots kind of probably just an extension of the blind spot. You got one there in the macula. Jumping over to the left eye, you got a 35 decibel. Again, it tells me with 20/20 vision that they get the test. It's kind of a little warm up. I like that. Total deviation looks good. Pattern's got a couple spots in it. Nothing really jumping out. Within normal limits on the glaucoma hemifield test, 100% on the visual field index, where mine is 0.69 diffusely scattered. So there's relatively a clean visual field, in my opinion.
All right. And here's his OCT. Why don't we take a look at this, Greg, and give us your thoughts?
Certainly does not match the visual field. I got a comment that says, "Good quality fields tonight. Kudos to the technicians." Yeah, absolutely, James. I don't know Joe's technicians, but it looks like they're pretty good here. And then there's, I know for sure I can't live without Sarah and Tiff in the office and Susan as the technicians. All right. Well, I don't know where to start, but let's start with the B scans where I always like to look start. And so at least we have the nerve. That's good. Sometimes it's the macula. Sometimes it's not even the optic nerve. That's why I like looking at those. And then jump down to the macula. It looks like you got some drusen in there, so that can influence some of the macula scans. So but at least we got the macula. Again, this cup here, I'm not sure if they're cutting through it looks like it's through the center over here when I go look at the left image. So it's just a shallow cup, and then the macula down there again looks like it has a couple drusen. Going over to the ganglion cell actual numbers. It looks like it's 76. So it's a little fuzzy on the
Yep.
screen the way it's projecting, but it looks like 76, 85, 83, 87. What's that bottom number? 68?
69.
69. So I don't like all those reds. And then if you look at the difference between the eyes, 9, 4, 14, looking at the focal loss volume, it's saying you better scratch your head. It's very focal. It's not only focal, it's diffuse. That looks good there. Green, where Joe has the 0.93. Again, don't worry about the number, it's a percentage. But it's also saying that the left eye is also kind of generally thin. So they're both generally thin, but then there's a little focal loss in that right eye. And if you jump over and look at the scans, go into that T-SNP of that right eye, 126 down to 82, that is concerning, which kind of loops over to that kind of that defect. Would be like a wedge defect over into the macula. So that it's certainly concerning for glaucoma. And then the glaucoma prone zone in the left eye, 116 compared to 126 above, and then 115 compared to 82. So glaucoma suspect, definitely, if not glaucoma in the right eye, maybe some touch of it in the left eye when you look at the ganglion cell map there.
So polling question number 5 is, do we treat this patient with meds, treat with SLT, observe, or do something else? Now keep in mind our pressure is ranging the 18 to 21 with about a 570 cornea.
What time were those pressures, Joe? Do you have any idea?
I don't.
Okay. People are giving answers. And what's your decision factor in running CETA standard versus CETA faster? We'll probably come back with another talk. I have some information towards the end there, Sam, but let me just tell you what I do for most of my patients. I do for glaucoma. Again, glaucoma, not looking for neuro disease and everything else. I usually do CETA standard. Um, and then if they graduate based on my technician, I'll go to a CETA faster. CETA faster is great. It's out there, but when at the last few OGS meetings, there's a lot of noise and it's so quick. And so what I like about the CETA standard is that it crosses the threshold twice. So they can see it, they can see it, they can't see it. So that's one time. Can't see it, can see it. That's the second time. And, we're trying to make decisions on treat, add second meds, SLTs is what the polling question here has. Observe. I don't want something that's, just crosses one time and there's a big gap in there and the instrument's trying to do it. So in glaucoma, I like to do CETA standards and foveon for the reasons that I talked. Would you like to get a cup measure from previous OT? Treat, that's for you, Joe, and treat provided other than explanation. Okay, so let's go back to the poll. Maybe display. We've got 63 saying treat with meds. We got SLT 6%, observe 27%, and then they put the comments already in the chat box.
What was SLT? What percentage was that?
6.
Okay. I'm actually surprised it's that low. SLT is really becoming more popular since the light study, but I think in real life clinical practice, it is not as impressive maybe as the clinical studies, but it certainly is an option. This patient decided we treat with latanoprost, so we initiate the medication. Comes back a month later, pressure is now 12 and 13. He is one of my snowbirds, and I think he was seen by his optometrist or ophthalmologist up north. So this is not a area of non-compliance. He was just not available, but he was using his medicines and was following up. In where I am, we have a lot of snowbirds, Greg. So I do a fair amount of custodial work. We have patients who have an optometrist or an ophthalmologist where they live up north, and when they come down to see me, I am checking their pressure. I'm reporting back to their primary doctor, and I'm refilling their medicines. But I don't, make major changes without consulting. So snowbird patients will often see many doctors. Is this a good response for you?
That's a hell of a response.
Okay. All right, so here are the visual fields over time. You want to take a look at that.
Let's see. Is that 10/20 of the 2020? Is that what that means? Yeah,
Yes.
October 20. So we're going about 3 years here. So um, we've got I'm just looking at what you've done here. So you got to see the standard, see the faster, and what's the next one? What's the last one?
CETA faster. My
See the
preference,
fast.
and I agree with you, Greg, is CETA standard. I usually order that. I use CETA faster for my neuro-op patients because neuro-ophthalmic disease is not subtle, not like glaucoma. But unfortunately, sometimes when a technician pulls it up, they pull up the wrong one. And I look at that, and I just don't have the time or the inclination to send them back into the room to do it again.
And what year did treatment get started?
It got treated right about, let's see, I don't think I have a date. So it would have been October 2020. So We began treating right about here.
Okay, it's October. So the first visual field. And I always like to know that because, I've been following patients for, over 20 some years where I am. You'll see them decline and then all of a sudden you'll see them level off. And you got to remember to the audience out there is that you kind of almost have to re-baseline them where treatment starts because it's going to pull off, the data that was before treatment. And so that can really, kind of can throw off what's happening. So you can kind of say that the first visual field here is pre-treatment, and then that was minus 0.2, and then went to 0.17, which is stable. And again, it's just saying it's diffuse. That's what pattern standard deviation tells us. And then, we jump over here, and now we're to a minus 2.13, which is a pretty good change, and that's why it's flagging it in yellow. But it's diffusely scattered, and you're kind of getting that superior, defect in that total deviation. So that's, I mean, this is the right eye. That's a true defect, and it's minus 2.13. So
And this is your typical early glaucoma defect, the small, shallow, fluctuating scotoma. Now, I wouldn't be surprised if another one comes back and is completely clear. But it's the whole area has been damaged. So here are the OCTs, and I don't have it neatly into a change analysis. So why don't you tell me, why don't we walk through this, Greg, and tell me what you think?
just read me the I have mine blown up here, but just the way it's coming across. In the optic nerve head in the inferior temporal, the initial was what, 82, if I remember
I
correctly.
think it's 82, yeah.
And
And this
then
looks
what did
like
it
76.
okay.
And this one looks to be 82.
Okay, and what's the one down below? That's the last one.
82.
Okay. So I mean,
So
sounds like you
82,
got
76, 82.
yeah. So it sounds like you're pretty stable there. Again, I looked at all the B scans. The B scans all look good. At least we're getting optic nerves. We're getting maculas. And then what is your just do the I guess the average GCC in October of the right eye.
Oh, it looks to be about 76.
Yeah. What's it then in February of 23?
I think it's 76.
And then down below there.
I think it's 76.
Yeah. So I mean, yeah, it's one of those. If you didn't treat, what would have done? But anyway, it's pretty stable.
Mhm. All right, so we're going to continue the patient on treatment and follow him at the
Let,
appropriate intervals,
let
which
me take a look
usually
at
for
the
me
right
is
eye
4 months.
real quick. Let me just take a real quick. We're kind of ignoring the right eye. Glaucoma is usually bilateral. It's asymmetric. You got a
Mhm.
defect over there. I can see 145, 145, and it looks like 145 or 146. So um, I'm pretty happy with everything there. So.
All right. All right. Anything that we should be addressing in the chat room?
Yeah, here's a good question. Based on those visual fields, it didn't come in that way, but I'll read the question now. If you see a really bad GCC, but a decent 24-2, do you run a 10-2?
That's a good question, Greg. Why don't you handle that one?
Yeah, that's probably since the 24-2C came out, and we know that now glaucoma is a macular disease in a sense because we're doing GCC. Um, have I been doing it for 29 years of practice? No. Have I been doing it over the last 5 to 6 years? Yes. And based on that visual field in that right eye being so clean, I would probably have run a 10-2. Not sure I would have done a 24-2C. Again, another one of those where they said at the OGS it's pretty sloppy. Um, a lot of some assumptions going on. But so I'd probably run a 10-2. But we've already treated this person with a good response, but still get a baseline and follow them from time to time.
You made a very interesting comment, Greg. You say at the OGS, I didn't go this year. They're saying the 24-2C is sloppy, or is that falling into disfavor?
Well, I'm not sure it's falling disfavor. They're just giving some caution out there to, kind of stick with your CETA standards. Watch out for your CETA fasts. Because I think that the 24-T, I'd have to look. I have it on my instrument. I've kind of migrated away from using it. I will use it if I don't want to do a 10-2 on a patient.
Hmm.
But to me, I want to get a more 10-2 type patients. I'm not saying it's falling out of favor. They're just kind of throwing caution to the wind. Just don't get away from your 24-2s and your 10-2s. So they're
Excellent.
all tools in the toolbox, I guess is the
Yeah,
best way of doing it.
Greg, I never liked the 24-2C. I don't know why though. I can't tell you why I didn't like it, but it just never caught on for me. But I think the comment from the audience member about doing a 10 on this patient probably is I think a very good idea.
Yeah, if you go back to the visual fields, go back to the OCT, if in this case, and I'll just show the audience. I mean, you got pretty much a clean visual field there. Go back to the visual field. I'm sorry. And so what we're talking about is you see how bad that defect is in that macula, and you kind of have this kind of mild-ish defect. And then if you go forward, Joe, to the OCT, that defect, the red jumping out, is huge. So a 10-2 is great. And probably the clinical pearl that I'll add to a 10-2 is when the macula is involved. I think this is the general consensus. When the macula is involved in a higher, when the defect is affecting the macula versus kind of that peri or area, you're going to treat more aggressive when the macula is involved. So when someone says, why do a 10-2? Why are we concerned about the macula? The closer the defect is to the macula, probably the more aggressive you want to be as a clinician, as opposed to it being kind of or parafoveal defect.
Excellent. Any other considerations here, or can we move,
Nope,
or
I
should we
think we're
move
good.
on?
Yep, I think we're good to move on.
All right, 71-year-old. It seems like they're all the same age. 71 year, and I guess it's unique because when I practice in Venice, the average age is I think 65. I've got more patients over the age of 90 than I have under the age of 23.
Yeah, I had a
But
pediatric patient the other day. He was 43 years old.
so this is a 71-year-old female comes in for a comprehensive exam, no complaints, type 2 diabetic. Moderately hyperopic, 20/20 in each eye, no afferent defect, pressure is 24 in each eye. Pachymetry is average of 563, 567. Gonioscopy, she's got pigmented trabecular meshwork for 360 with moderate pigment. Biomicroscopy is normal. She's got a grade 1 nuclear sclerotic cataract in each eye. About a 0.7/7 right eye, 6/6 left eye, no focal rim abnormalities. And I do want to stress that this is not all one visit, is the pressure at 24 that necessitates coming back for pachymetry and gonioscopy and all the other testing. Is there anything you want to ask here before I show you some images, Greg?
Nothing I want to ask. I do want to now, out of all the cases that you've had, this is really one where we can now start folding in the central cornea thickness. Your first case you had, the patient was 11. They could have never been put in the ocular hypertensive treatment study. The next one was 20 and 22. They could not have been put into the ocular hypertensive treatment study. Now you have a patient of 24. Now, I don't know the imaging, if they're clean or not clean, but the only thing I would say is that these central cornea thicknesses really don't do nothing for me. It doesn't increase the risk. To me, the two numbers I use are 500. If this would have been 24 and 500, I would have said, okay, a little bit of added risk. 600, a little bit of a decrease in risk. 563, 567, it's 24. I use the ocular response analyzer in my practice, and it gives me the cornea hysteresis. I find that to be a little bit more powerful than central cornea thickness. Obviously, you don't have it down. Doesn't sound like you have it down in Venice, so that's no big deal. It's just another biomarker. It's another measurement that's out there. But this central cornea thickness really doesn't do much of anything for me.
All right. Here are the optic nerves. You want to take a crack at them?
Well, I'll start with the left eye. I'm just real quick. I mean, there's this whole analysis that's out there. But I just kind of do the isn't rule. I'm a clinician. I look at it quickly. Um, I mean, it's kind of hard to tell if there's a nerve fiber layer defect, but the isn't rule, inferior should be thicker than superior, than nasal and temporal. I see no violation to the isn't rule. And I do now, when I look at photos, like to take a kind of a second and third look just to make sure that there are no disc hemorrhages. I don't see anything in the left eye. I'm not sure if it's a magnification issue, but it probably, if we'd measure these with all the different types of parameters that are on our cameras now, we'd probably find that this disc is a little bit larger, or like maybe macro disc-ish on the right. Looking at the isn't rule, just being real quick and dirty. The inferior might be thin because it looks to be equal to the superior. Maybe a little notch right where Joe is there, but that's enough for me to kind of follow this patient. That looks good there. Superior, nasal, temporal look good. Kind of hard to tell if there's a nerve fiber layer defect, but out of all these optic nerves, they look great. Maybe because it's a macro disc, a little bit larger, but in stretching it, but there might be a little bit of a loss inferior. But I just have a patient the other day, a notch, and the next patient come in, I'll probably put in a glaucoma talk. One's a notch from glaucoma, one's not a notch from glaucoma, but suspicious on the right eye, be my opinion.
All right. So here are the images. And we've gone pretty in depth. So why don't you call out what you find to be significant in this one?
Yeah, I don't like just real quick. I mean, I can see the optic nerve in your right B scan there, but technician's good. But if you look where the red vertical line is, it's not really kind of going through the cup there. So it's
Correct.
somewhat misaligned. It's hard for the patients to get lined up right there. You see the red line, how it's cutting through there. That's why it's so shallow. It's not going through the cup. So this nerve is kind of pushed, if you want to say, I guess, I don't know, temporally. Now that's going to kind of throw off the parameters going around that ring because you want it centered, right? And that's why macro disc and micro disc, because it always measures the same amount in the center. So you got to be a little bit careful with these. It's not a centered nerve in that right eye. So it's probably why it's flagging that superior nasal is being red. If we kind of push everything back over, and that blue would probably disappear and everything would be okay. So you get a little misalignment in the right eye. Looks like the macula is pretty good in the right eye. The left eye, again, I like looking at the B scans. The right looks good. The left looks good. You got well centered on your nerve fiber layer there. You got a superior thinning in that superior glaucoma prozone, superior temporal, inferior temporal. You got a bunch of GCC. And now let's go over to the nerve fiber layer again. 5, 2, and 8 in the difference. Not too bad. Again, a little misalignment, so be careful with that. And then your GCC, if you look at the right eye, 87, 87, 86, and then you drop 10, 8, and 10. Yeah, I mean, there's concern. What's the is this patient a high myope at one point or anything like that?
Hyper up, actually.
Okay. Yeah, nerves pretty big for hyperopia
All
too.
right.
So
And here are the fields. Walk through this. I like these cases because this is real clinical cases, because we're going to have artifact in the fields, and we're going to have artifact from time to time on the images. And we have to pick up that artifact and understand, what is the implication overall. Why don't you work through this for us, Greg?
well, You got a rim defect superior. I'll just go right off. But let me just look and see what we did here. 5 minutes. We got some false negatives. Patient's getting a little sleepy. Again, now see it's a plus 550. I might have maybe numb the eye and put a contact lens on this patient. And I start to get up to a 550. See the standard good, but now if you look at the raw data in this left eye at the very top, you got an 8, a 0, and a 19. Those zeros are probably not a defect from glaucoma, or it's probably the rim blocking it up there. So now we're going to kind of throw some things off here when we go down. Total deviation, nasal defect, uh, total deviation, pattern deviation. Got to be careful with that -5. It's probably not as deep as a -5 because of the 2 zeros up there in that 8. Because you can see how localized it's saying. See how that pattern standard deviation jumped? It's saying it's localized. So you got a nasal defect, but you also, these numbers are being thrown as being a little deeper than they probably are. So you gotta be careful with that. Because I look at the mean deviation, 0 to 5 is a mild defect, 5 to 10 is a moderate defect, and anything above a 10 is a severe visual field defect. And so how we got to the 5, and we're saying, ooh, moderate, but it's probably not as deep as we think because of that rim defect. But you got to be careful with that nasal side there. And then the right eye, looking at the raw data again, probably getting in superiorly. That there's 11s and 13s. Those are probably getting kind of rim-ish defects. But you got a nasal defect, and then you jump over and you got a 91 on the visual field index. See now it's -3, not as deep because you don't have as much, kind of rim defect, and it's localized. And so I think you got maybe a nasal defect in each eye, but you got some rim issues going on too.
Yeah, there's some artifact in here, but not all of it. Some of this is going to be, is going to probably be real, particularly when we look at the structural analysis. We have to begin to believe some of it. So it gives me polling question number 6, Greg. What do we do? Do you treat this patient with medicines? Do you treat her with SLT? Do you observe her, or do you want to do something else? If you're doing medical treatment, what medication would you use? You can put your medication in the chat box.
Okay. Polling question is open. What were these pressures? 24?
24s.
Wow.
Average pachymetry.
And that nerve, that left nerve looked good, right? That was the nerve that looked really good. It was kind of small. The other eye was a little bit bigger. Go back to the OCTs. Let them look at the OCTs. Yeah, that's the optic nerves.
So what are our trends, Greg? What do people want to do?
We have treat with meds, 53% is the winner. SLT, now we got a little higher at 28%. And we got observe at 10%. And if medication, what medication, I'll put it in the chat box. Let me go see what's there. Basically, latanoprost, prostaglandin, prostaglandin. So we're starting with
Excellent.
prostaglandins.
And sorry, what was what I missed the poll trend? What was med and what was SLT?
SLT went up. Meds was 60 and SLT is 23.
Okay, so people are still doing medicines. All right, so let's talk about it. She's diagnosed with primary open-angle glaucoma, which I would say moderate stage at least. Now she comes back, her pressure is 26 and 28, and I start her on latanoprost. She did have an initial response, but she complained of blurred vision with generic latanoprost, wanted a branded medicine. So I sampled her on Zelpro. She comes back on Zelpro and she's 24 and 26, and she tells me she is using the medicine, but she doesn't like the Zelpro, so she wants actually branded Zalatan. So I obtained branded Zalatan for her, and her pressure was 24 and 24. So we did have what was an initial response with a generic that she didn't like, and we did two branded prostaglandins, and this is what we're at. And you can see she's still in the low to mid 20s. So it brings me to polling question number 7. Do we try another branded prostaglandin? Do we treat her with SLT? Do we switch her to a combination agent? Do we add a combination agent, or do you want to do something else? And that, you can put that in the chat box.
I'm not sure
It
if I
seems, Greg,
have.
like we're getting good interaction with our audience virtually.
Yeah. I'm not sure if it's a copy and paste issue whenever I sent it, but I don't have try another branded in there, but it says treat with a med. So we'll use
Okay.
A as that. SLT is good. This is observe. I don't think I have, yeah. So it's the polling question is not matching the, so if you guys want to use the chat box, if you want to try another branded or switch to a combination, I have treat with med, treat with SLT, observe. So probably my error in copying over.
No worries. It could have been my error on the document that I sent you. So we can put it into the chat. Do you want to try another PGA, different branded one? SLT, switch to a combo agent, add a combo agent, or maybe something else. What are they all saying, Greg?
Yeah, there's some good comments rolling in here. Switch to Lumigan. Um, at least discuss SLT. We've got a COSOPT coming in. Add a combination medication. Would discuss SLT. If refuses, start combo drop combo. SLT previously, now add combo. Switch to combo. COSOPT, switch to COSOPT combo. So
And I can say all reasonable. All approaches are reasonable. What I don't like in glaucoma discussions is when a bloated pundit tells an audience, this is the way it should be. There's many options that are very good. Our goal is to minimize the patient's vision loss and minimize or decrease in quality of life with our treatment. And how we get there can actually vary. All right, so this is one of those rare people I come across, which I actually suspect that she is a non-responder. I've tried a couple times, and we're not really getting a sustained pressure reduction. So I stopped the prostaglandin category for now, knowing that I can always go back to it with another branded one later, maybe a latanoprost Bunod, and I prescribed a generic dorzolamide timolol, and her pressure actually now comes down to 15 and 16, consistent over several exams. And to me, that supports she was more a PGA non-responder than a PGA non-adherent patient. Do you agree, Greg?
oh yeah, I agree. Yeah, and Joe, I'm going to kind of go off on a tangent here. This is kind of like the functional medicine side coming out, and I sat down with one guy one night at the academy who did his PhD. He's a medical science liaison. He's a PhD. He's a doc, but not an optometrist or an ophthalmologist, and he studied the trabecular meshwork. And the trabecular meshwork, the receptors for the prostaglandin are becoming oxidized. This is the disease. The disease is at the trabecular meshwork. So the functional side of me is coming out saying the body again is talking to us here. This might be someone where I might go a little bit of fish oil and a comprehensive antioxidant too, because if they're not responding to prostaglandin analog, we know that there's some oxidation going on. So I'm going to pause there because I don't want to turn it into functional medicine, but I want people to realize that the disease is at the trabecular meshwork, and these non-responders, are telling us that there's something going on there.
And the true non-responders are not that common. Usually the non-responders are non-adherent. This one, based upon the response to the sustained response to a combo agent, tells me that it wasn't an adherence issue. It's more, I think, a true non-responder. Now, here are her discs, and what I want to point out, if you pick, I'm sure you'll pick this up. What do we have there, Greg?
Yeah, on that picture on the left, there's a nice hemorrhage down there. So.
Yeah. So here's a patient under treatment who now develops a disc hemorrhage. So there is change happening at the level of the laminar cribrosa. And here are her fields. Now I'm going to say the one on the right was the baseline photo. The one on the left was during a follow-up visit while she was under treatment. So pressure has come down. I think we learned from the early manifest glaucoma treatment study that you can't stop disc hemorrhages from occurring by lowering pressure. They do still occur. So this is baseline on the right. This is a follow-up on the left. The only difference I see is the disc hemorrhage. And here is her visual field over time. What are your thoughts here?
The visual field on the screen, Joe, on the right side there. What's the date of that one?
This is
Because
2023 and this is 2021. So
okay.
the one on the right side is the more recent one while the patient has been under treatment.
Okay. I'm looking at what the audience is seeing because I had to make it big, and there's a picture of me or you, whoever's talking, covering up the date. So that's why I had to ask. So let's see. So let's go back to the original. I'd like to see you're still using a 550 and a 550. You can see that maybe they moved it closer to the eye. The rim defect is less. So we're worried about that nasal defect. The nasal defect is still carrying over in the more recent. And you can see that the mean deviation went from 3.78 and it's localized at 4.32, jumping over. And after treatment, we got an improved visual field. I'm not saying treatment can improve a visual field, and we can talk about that if we want, taking the stress off of kind of the wounded ganglion cell and nerve fiber layer and allowing it to recover. But you can see it went from minus 3.87 to 1.13. So we're all, almost normal. And it's kind of now more diffusely scattered, not as localized. I mean, change progression. I think you got an improvement and things are stable.
Yeah, I think the improvement, Greg, is just better testing. This is probably more on the right, more indicative of what's happening. And I like to say, we don't need to lose our nervous system every time we see a disc hemorrhage and think that we're failing. Yeah, she developed a disc hemorrhage at a statistically lower pressure, a significantly lower pressure, but we can see that she is not progressing. We're probably just getting better testing. Here is her left eye. 21 on the left and 23 on the right.
Yeah, I don't like that inferior quadrant down there. What's going on down there? It's almost all in the left eye in the 2023. I mean, you're down to zeros and sixes and eights, and I mean that's a pretty good change. You got, if you look at that horizontal coming down where it's 21, 20, 24, 25, then 29, 27, 24, 14. 14 could be a rim defect, but 29 to a 4, 29, 27 to a 7, 24 to 11. That's a pretty deep change and a pretty deep defect. That's why you went from 5.87 to an 8, and you went from 7.72 telling us that it's localized to even more localized, very deep in that area. And you can see it with the numbers up there and the pattern deviation where they have all those 18, minus 18, minus 14, 21, 26, 19, 23. I'm not sure if that's glaucoma. There could be something retinal going on.
I don't know if there's anything retinal going on, but always, for the audience, always understand that visual fields do change. People do have bad days. And what we need to do is repeat to see if this is actually real. But we can just take a quick look here to see what's going on structurally. What are your thoughts here?
Um, let's just look at the right eye, the glaucoma prone. See this where you gotta be careful. See your right eye, see how that red line is right
Mm-hmm.
through kind of that there. Now your other eye's lined up. So now things are gonna shift. So we just
Mm-hmm.
gotta be careful with the numbers here. But 114, 124, that's probably a change because of the shift. This might get a little thicker. Um, uh, yeah, you can see what happened down there at that. Look at that inferior temporal of that right eye. What was it? 99, and now it's 120 something, 107, just
No,
shifting it
I think
over.
102. I think that's 102.
Oh, 102. So it's just
Mm-hmm.
shifting it over. That's where that thickness came from. So that's just more of an alignment thing. So just be careful. That's just, always got to check your alignments. But, things look stable there based on alignment issues and your left eye. They're always well lined up. So I can't see the numbers because they're in red, Joe. So you have to read them off.
This here is a 73, and this is a 73 as well. So that inferior temporal zone did not change.
What about the superior temporal?
Superior temporal looks like it's 80, and this is 79.
Yeah, so things look stable. The
So there's
glaucoma,
no
the
structure.
GCC map looks good. So it's 2 year change too. I mean, that's 2.5 years, so that's good.
Yeah, so the issue here is yes, it does look like there's been a significant change, but structurally the patient did not change, which makes me suspicious that this is a testing bad day, which I think I did repeat it, and she did improve. Now, the interesting thing on this patient is she kind of disappeared for about a year or so. Now she's come back, and I can tell she's going to be a bit of a management challenge. She's nice enough, but she's always in a hurry. Doesn't seem to really appreciate the gravity of the situation. And was telling me how she moved 6 times in 1 year. She's had a lot of stress in her life, so hopefully, I'm going to get her back pretty regularly. So, Greg, I think we have just hit it. I was really ambitious tonight.
Hmm.
We have several more cases plus some visual field analysis. So, if people like it, we can come back and finish the rest of this at another webinar. I think, Greg, it's probably time for us to start landing this because we're right about that time. Is that correct?
Yep, I agree.
All right.
While that's happening, if you unshare, I'll go to the last screen. But we do have a question they rolled in. I think it's a great question. Do you ever treat with SLT if you suspect the patient is non-compliant?
I think that's a great option. In fact, when you think the patient is not being adherent to your therapy, treat with SLT. Here's one more caveat that I'm going to give everybody that I have learned in the hard way, maybe even painful way, is that we all have a bias for with medicines. Because from the very first day of our training, we're putting drops in people's eyes. We go to the drugstore or the grocery store, there are shelves of eye drops. We have a bias that we think patients can use medicines. They may be adherent, but they may not be able to do it. So I've learned whenever I have a new patient or if I'm prescribing medicine, one of the first things I ask is, can you use drops? Do you think you can use drops? And then I will actually show them with an artificial tear a method of doing it. So I think we probably have to be aware that we are a little biased toward medicines that we think everybody can use eye drops, and they really can't. But if you
And
think they
then
can't use eye drops or won't use eye drops, SLT is a very good option.
And then the last comment that I'll make is, Lynn, yeah, the answer is yes, go to an SLT. But then what I want the audience, and maybe majority are aware, maybe they're not, but SLT is going to really, I think, take off in the next few years. They're looking at SLTs that can be done externally. The instruments already, I think, approved. They're going to be approved. We're talking about, not even having to use a prism. We're talking about low level SLT, very low level, treating 360 degrees, and then coming back a year later, doing it again, very low level. So I think SLT, because this is an outflow disease, I keep your finger on that pulse. So, what would be the diff? I'm not sure what the. Do you know what that question's coming from? What differential? I don't know what the question
I don't
is, what
know.
would be the diff? Ken, if you want to, Kenneth, if you want to put more information, I'm sorry, I'm just not connecting everything. Trans hemorrhage in a 25-year-old. What would be the differential in a 25-year-old?
A Drance hemorrhage in a 25-year-old, I would think a blood dyscrasia. Not all hemorrhages of the disc are disc hemorrhages.
Right. I agree. Wouldn't be probably PVD. I'd be thinking something systemic at that young. So like Joe said, blood dyscrasia. Well, he's going with that, like leukemia, anemias, those types of things is where I'd be
Mhm.
maybe some autoimmune. Why
Well,
change to combo med before trying Timolol first? Yeah, you could do
uh,
Timolol first, but
that's
you know,
reasonable.
yeah, there's no right or wrong out there, as Joe said, for those guys that beat their chest, so on and so forth. Timolol just works kind of in the morning. You lose that effect at night. There's no beta activity in the ciliary
Mhm.
body to block. So now you're kind of treating the patient half a day, but it still works. I still use it a lot of times as my prostaglandin at night, Timolol in the morning. Usually Timolol if there's a prostaglandin on board. I just think that we've probably had so many failures over the years that instead of just jumping to a Timolol and a single agent, we know this pressure has to come down. So the COSOPs and the generic Combigans come out. So, but you could certainly
Uh,
do it. There's no wrong answer.
oh yeah, I used to be a purist. I always said and taught you try one agent or the other.
Can a
But
low
now
pulse rate cause a disc hemorrhage?
I
Um,
don't think so. I can't see how that it would.
Yeah, because remember that the eye auto regulates. So if you get a high blood pressure, low pressure, the eye can auto regulate. So just remember that that's out there. It's probably more sickness, like Joe mentioned. So while we're answering the questions and we're moving on here, the polling question right here, I can see it says survey. There's that little red dot that's out there. So you could start that survey question now if you want. So if you look at your screen, I can see it, chat, poll, notes. You'll see the little red dot. If you click on it, you can start that survey, or you're going to get it in 3 minutes. That's out there. So with that said, there it is. And Joe, I'm looking at the questions. I don't see any other. So I want to thank everyone for attending Glaucoma Clinical Case Conversations. This was a synchronous virtual course. Joe and I were the presenters. Thanks, Vanessa, for being here as OEC webinar administrator. Joe, any final comments before I do some housekeeping?
No, I mean I enjoyed doing it. I enjoyed listening to you write the songs or Elton live, so I really appreciate it. I thought you did a great analysis. One thing as a speaker, we never want to end early and have dead air, but way too ambitious in this talk. So I think we'll have to come back and finish the rest of the cases and some visual field discussion later, Greg.
Perfect. I agree. Thanks, everyone. That concludes it.